What time is it back in Uganda at this point in Africa?
It is 9 p.m. East African time, 9 p.m.
Good evening to all my friends in Africa, and it's a pleasure to be speaking to you today and giving you a talk on the management and the evaluation of penile cancer. There's a lot of slides, and we're going to go through a fair amount of material, but this is definitely very informal. And if anyone has any questions, you can definitely raise your hand, ask a question. This is very informal. So I don't have any disclosures other than my involvement on the NCCN and also part of a new exciting society dedicated to rare cancers, which is really launched a few months ago, called the Global Society of Rare GU Tumors. And we've been very privileged to have some of our friends from Africa who have joined the society to know a little bit more about some of the work that's being done in education, research, and in patient advocacy. So as you all know, penile cancer is not very frequent in North America, but as you all see in Africa, for example, it is definitely something which is seen much more frequently and unfortunately is often presents very late. So it's important to have a high degree of vigilance to what penile cancer looks like, how to treat it, and some of the pitfalls in terms of management evaluation. So again, about 2,000 cases of penile cancer, and that's consistent from year to year. About 400 to 420 deaths every year, secondary to penile cancer, and it represents, as a general rule, less than 1% of all malignancies. Definitely, I would tell you in my practice, I see probably 2 or 3 new penile cancer patients a week. Obviously, my practice is somewhat unique. So it is something that is seen, unfortunately, in some high volume centers more frequently. An important thing here is that the staging system for penile cancer has changed. It's important to know that for test purposes and also for when you're staging a patient. T2 and T3 is now, cavernosal involvement is now defined as T3 and spongiosal involvement at T2. Urethra does not further distinguish T2 and T3. And then N1 versus N2, you can have up to 2 nodes positive as long as there's no external extension in N1, and N2 is bilateral disease or more than 2 nodes. And these are some of the differences between the staging systems. This is a review we wrote a few years ago. And this is what it looks like on pathology in terms of T1 versus T2 versus T3. So again, here you're seeing a tumor within the subepithelium. Now you see involvement of the spongiosal tissue. And then once the cavernosal bodies are involved, and you see here some cancer, then you go on to T3. Also, as mentioned, there is also some sub-classification of T1 and into T1A and T1B based on lymphovascular invasion and also a feature called perineural invasion. That's in fact what you're seeing here. These are the nerve roots, and you're seeing some cancer within these areas. So definitely something to be looking out for as well. Just want to highlight the fact that the staging system is improved versus what it used to be, and this is a review article we published with some colleagues from Asia. Shows the difference between T1A versus T1B versus T2 and T3 and T4. And again, you see some nice stratification of the curves, but it's still not perfect. You see your overlap of T2 and T3, for example. So again, staging system is better, but it's not yet perfect. Probably what's going to happen, we start to see that happening, and this year there will be some changes from the pathological staging system into HPV positive or dependent in HPV non-dependent penile cancer, much as what we see in head and neck cancer. Also to show that the incidence of doing an inguinal lymph node dissection, which is indicated for anyone with a T1 high grade or a T2 tumor, and you see only about a third of patients are undergoing surgery. Even at high volume cancer centers, that's only being done about 2/3 to 3/4 of patients. So probably still some work to do to optimize that. And also at the level of staging of the nodes, once external node extension or the pelvic nodes are involved, that's when you move on to staging of patients N3. The histology also makes a difference, and what I mean by that is certain subtypes of penile cancer, like basaloid, sarcomatoid, they have a very bad prognosis versus verrucous has a much more favorable prognosis associated with it. So spectrum of disease, not only related to the staging, but also based on histopathology of these tumors. This is something which is also very, unfortunately disappointing, is that you see that over time, the outcomes of penile cancer have really not improved, both in the SEER database from North America and also in the European database using UNIS. And that's printed over the last 25 years. And you're going to say, why is that? It's probably because the chemotherapy, unfortunately, as a whole, has not been very effective. Our colleagues from Fox Chase published this paper a couple of years ago in JAMA Oncology, over 1,100 patients. And they looked at what are the factors that predict how patients are going to do with penile cancer. They looked at data using a national cancer database called the NCDB. And really what you see is the utilization of chemotherapy has gone up to about 48%. But still, when you look at what factors predict how patients are going to do, undergoing surgery, meaning anal lymph node dissection, was the strongest predictor of survival. Chemo and radiotherapy did not improve survival. You see that here in terms of whether or not they had an anal lymph node dissection. And then you also see this here when you break down the curves by status of the anal lymph node dissection. So if they did not undergo an anal lymph node dissection, they did worse, irrespective of whether or not they got chemotherapy. And if they had an anal lymph node dissection, you see the curves are significantly better here. We published this paper also a couple of months afterwards, looking at data from two high volume centers from here and from Italy and from Milan. And you see, again, about 2/3 of patients are getting chemotherapy, but on factors predicting survival, perioperative treatment did not improve survival, meaning chemo or radiotherapy. So it's consistent with what our colleagues from Fox Chase in Philadelphia had found. The strongest predictor of how patients are going to do, and they often test this on exams, and it's important to know that clinically, is how bad or how involved the lymph nodes are. As the lymph nodes get more involved from N1 to N2 to N3, the survival curves get dramatically worse. So people always discuss the use of guidelines in management of penile cancer. It's really somewhat disappointing to see, even at high volume centers, following guidelines is not necessarily being done as frequently as it should be. And for example, we see that patients who have an indication for anal lymph node dissection, like I was saying previously, are only undergoing the surgery in about 3/4 of the time. Use of radiation chemotherapy, also not very frequently used. It is interesting to see that the proceeding with anal lymph node dissection is being done more frequently at most centers, both in North America and in Europe. But still, it's still important to highlight that this surgery is highly morbid. It probably should be done at centers that do a lot of it. And ultimately, we see the factors that predict patients being treated according to guidelines is also unfortunately related to several factors related to insurance, part of the country, and being close to academic institutions. I'm not going to get too caught up in histopathology and schematic and pathways, but just to tell you again, penile cancer can develop according to the HPV progression pathway, and about 50 to 70% of penile cancer is related to this through the E6 and E7 phosphorylation, and these are generated through the effects through the retinoblastoma gene and P53, and results on carcinogenesis or cell immortalization. It's also interesting to see the pathways in penile cancer are now better established, and we now have drugs that potentially can target these. So although we haven't done, I would say, a very meticulous job identifying effective systemic therapies, there's definitely some interesting work that's being done that probably will help improve this in the years to come. And this is also to sort of illustrate a lot of clinical trials in penile cancer are being done for other type of squamous cell carcinomas, meaning patients are being accrued, for example, for vulvar or cervical carcinoma of a squamous cell type, but they're allowing patients with penile cancer to be entered in these trials. So a little bit what we refer to as orphan disease trials, where there are some interesting compounds, including immunotherapies and combinations are being looked at, but these are being done particularly for other diseases in which squamous cell carcinoma is the underlying histopathology. This is also something which is, I think, very important. I think something also particularly for my friends and colleagues in Africa to be aware of. People always ask, is there a role for HPV vaccination for women? Absolutely. It decreases cervical cancer. It's been very well shown to improve survival. How about for penile cancer? Well, the problem with penile cancer, as we were discussing before, it's fairly rare in North America. So to be able to show that by vaccinating, you're able to decrease the incidence of penile cancer is very challenging. But there have been some studies which have shown quite well that by vaccinating, we're able to decrease the incidence of pre-neoplastic penile lesions. And it's also believed, and I would tell you there's not good data, so it's important to emphasize this, that potentially vaccinating people who have pre-neoplastic lesions of the penis, or patients, in fact, who already have penile cancer before they develop metastatic cancer, may boost your immune system to HPV and potentially result in a better response to treatments. So let's talk a little bit about guidelines. So the first important thing to emphasize is that about 10 years ago, most patients who had penile cancer, they were undergoing what we refer to as mutilating surgery. That means partial or total penectomy, regardless sometimes of the stage and the grade. And it's important to highlight, sometimes you could do a penile sparing approach where you try to spare as much healthy normal penile tissue, but it's important obviously to get clean margins and to do a reconstruction which are going to allow patients to work and function quite well. You see that in North America, the incidence of undergoing penile sparing surgery is improving, but it's still probably underutilized in most institutions. This is also an important factor. Back when I trained many, many years ago, they used to say you need a 2 cm margin regardless. Well, studies have looked at this, and in fact, this is one study from the United Kingdom, and they looked at the size of the margins, and they found that as long as your margin was greater than 1 millimeter, the risk of recurrence was really low. It was less than 1 to 5%. So the important thing is, if you have a good pathologist that's able to read for a frozen section, tell you whether or not you get clean margins, getting clean margins is the most important thing, greater than 1 millimeter. So very small margin is ultimately needed. So you can sometimes do penile sparing surgery in cases where we would have not done that many years ago. This is a paper we published a few years ago looking at penile preserving approaches, over 1,200 patients, largest series in the literature of penile sparing surgery. You see that when done, about 260 patients had recurrences. Most of these happened really early on, the first year, and most of these recurrences were treated with repeat penile sparing surgery. So even if a patient has a recurrence, oftentimes you can salvage them. And again, looking at that series, we did all sorts of different penile sparing treatments, including circumcision, wide local excision, laser, and for a bunch of various lesions. And the factors that predicted how patients did is the treatment type and the T stage. And you see, again, overall recurrence rate of about 21%. Most of these, again, were salvaged. How about treating what's called carcinoma in situ? Carcinoma in situ is that flat type of tumor, which is sometimes hard to pick up and it identifies as a red lesion or a discolored lesion. Well, if you look at this paper, which we published as well, looking at various forms of penile sparing surgery, you see that you have excellent outcomes, recurrence rates less than 25 to 40%. And most of these recurrences, again, happen fairly early on, the first year or two. And most of these, I would tell you, are highly salvageable. You do notice that the laser group had the worst outcomes with penile sparing surgery for carcinoma in situ. So that's why we don't typically do that at our institution. What I do in my practice is when I identify a patient, I feel confident the pathologist is calling carcinoma in situ, I actually use topical chemotherapy, and we use an agent called 5-FU or FUDEX, as it's also known. And the way it's done is it's applied to the area once a day for 6 weeks. Then typically the patient is seen back about 6 weeks later. If that doesn't work, we use another agent called imiquimod. Same thing, a topical chemotherapeutic agent. So what's the outcomes? This is a paper that was published from the United Kingdom. They did this in 86 patients. Complete responses were seen in 57% of patients, partial responses in 30%. So overall, 85 to 90% success, and toxicity was only 10%. We published this paper that was subsequently published just a few months ago, looking at toxicity, and you see, again, using what's called the CTCAE, which is what we use here to grade toxicity. Grade 3 or greater is defined as major toxicity. And you see very rarely do you see severe toxicity with these agents. They're very well tolerated. How do you manage the non-palpable inguinal lymph nodes? Meaning, someone has high-risk tumor in the primary site, so you do a partial penectomy or you do a glanzectomy. The pathology shows a T2 or T3 tumor, and there's an indication to do inguinal lymph node dissection because the risk of having positive lymph nodes can go up to 50%. Should you do surgery then when they don't have palpable nodes, or should you wait for the palpable nodes to show up? So this is one of the early papers, but it's an important paper published in 2005. It looked at this with 3-year outcomes. And it showed early surgery did better for these patients. So what you see is if they had surgery early, this is how much better they did in terms of disease-specific survival versus delayed surgery. And when we looked at this as well, we tried to define, well, what's that timeline? When should you get the patient to the operating room to really impact outcome? And the number we came up with is 3 months. When we looked at it in our patients, if we waited greater than 3 months, they did worse in terms of overall cancer-specific outcomes. And these are, again, early versus late based on that 3-month time interval. Well, what do you do if someone has a palpable inguinal lymph node? Should you treat them with antibiotics for 4 to 6 weeks? Should you do a biopsy? So this has also changed in the last 10 years. We used to say, well, treat them with antibiotics, and if they still have a node, you biopsy or you remove it. Well, we don't do that anymore. If you can get a biopsy of that lymph node early on, either under ultrasound or if it's clearly palpable, just a core biopsy, it allows you to minimize the delay to treatment. And therefore, that is the recommendation. Now, do you ever do antibiotics? Yes, if you have an infection of that area, obviously you want to treat them with antibiotics before you do surgery. Now, biopsy is very diagnostic and therapeutic, so getting a biopsy is probably the right thing to do. And this is the NCCN guidelines. I know they've been adapted also for various parts of the world, including in Africa, so it's important to look at those. So you see if someone has palpable lymph nodes and they're small, you can clearly do a biopsy, and if it's positive, go on to surgery. If you clearly are suspicious based on the aggressive nature of the primary tumor, you can go straight to surgery, and you can even consider giving chemotherapy before surgery, particularly if you feel they may have more cancer than meets the eye, or if you're concerned about proceeding with surgery. How do you do the approach? I was mentioning I just did this surgery just literally 2 hours ago. I typically will do an incision right below the inguinal crease, about 1 centimeter. This is usually a 12-centimeter incision that I do. Sometimes we do a midline incision to do the pelvic lymph nodes, or you could do lymph nodes laparoscopically as well. And this is what you see. You clearly see the various muscles. So you have your sartorius, you have your adductor longus muscle, and then you have your triangle right here, as you're well seeing. And ultimately, what you're doing is you're swinging and covering the blood vessels, as we're mentioning here, particularly if they're exposed. So what's the morbidity of surgery of inguinal lymph node dissection? Well, it's quite high, and that's oftentimes why both patients and surgeons don't like to do the surgery. Well, overall, when you look at the complication rate, and again, this is one of the papers that looked at this, the complication rate is about 50%. Most of these are minor complications, about 2/3 are minor complication, about 1/3 are major complications. These are the typical complications: wound infection, sepsis, wound dehiscence, lymphedema, blood clots. Those are all things to watch out for. You could treat patients, and you should treat patients with antibiotics after their surgery, particularly if they have the drains in place. Very meticulous, be very delicate with the tissue, make sure your skin flaps are not too thin. Those are some of the things you can do to minimize those risks. We published this paper a few years ago, looking at complications across a large number of institutions, over 320 patients. The rate of major and minor complications were looked at. As in the prior slide I showed you, about 55% of patients had complications. About two-thirds of these were minor complications, 1/3 were major complications. And this may not be difficult to see, but the factors that predict the complications is the more lymph nodes you remove, the higher the pathological nodal status. Those are typically when you're going to have more complications. So it comes down to, if you do a more extended surgery, you're going to have higher rate of complications, and that's what you'd expect. These are the typical minor and major complications. Wound infections are the most common ones, seromas, so fluid collection. So it's important to leave a drain after this surgery. Major complications are related to wound infections, skin necrosis. Those are really the common ones we see. How about doing laparoscopic or robotic surgery for these patients? So this is one of the earlier, but one of the probably the better studies that were looked at from the group from Emory University in Atlanta. They looked at 29 patients, of which 9 patients had penile cancer, the others had melanoma or other malignancies. And the rate of complication with laparoscopic surgery was really quite low. Only about 15% of patients had major complications. And this is how it's done. So typically 3 trocars are placed. The first one is fairly close to the knee. A balloon insufflator is used to develop this plane. And then you follow the same anatomical landmarks as we were talking about, the adductor longus, the sartorius, the inguinal ligament. So you follow those, and you skeletonize the vessels as you would in open surgery. Oftentimes you take the saphenous vein, and sometimes what our colleagues often do is they take the superficial and deep lymph nodes together. So, as you probably all know, when you do an inguinal lymph node dissection, usually what you'll do, if you have the capacity to do so, is you'll send the superficial lymph nodes to your pathologist and you'll ask if there's any cancer in them, and that'll help you determine whether you should do a deep lymph node dissection. If that's not available, unfortunately, you have to go with your clinical impression. And if you're suspicious, then obviously you want to remove all the lymph nodes where cancer could have gone to. This is a paper that was published from the group from India. It's the largest experience with robotic and open surgery. They compared open versus robotic. So again, largest robotic experience of 51 cases versus 100 open surgeries were compared. These patients were matched, meaning they were very comparable in terms of their characteristics. And when you look at the rates of complications of those two groups, you see a much lower incidence of complications in the patients who had undergone the robotic approach. How about using single port surgery? This is becoming also very popular, particularly as the robotic single arm robot is now being used. I would tell you it can be done. There are benefits, obviously, by putting less trocars in these areas. People always ask me, well, when should we not do robotic or minimally invasive surgery? So if these patients get chemo and radiation therapy, or they have bulky disease, or they got radiation, you shouldn't do it. Again, just the case I did just literally 2 hours ago was a patient who got chemo and radiation for bulky nodes. This is clearly an appropriate one to do using open surgery. You have to get behind the blood vessels. You have to skeletonize the blood vessels. It's important to remember you got one shot to do the surgery well. If you miss it, these patients are going to do very badly. How about doing a sentinel lymph node biopsy? This is a technique where you inject a dye, both a technetium dye and colloid blue dye together. And we looked at this when I was a fellow many years ago at MD Anderson, and the false negative rate with this approach was 18%. And this is what it looks like. So you inject at the partial penectomy site using the blue dye, and then you look at where the lymphatics are, and you can see the lymphatics are draining to, and you can follow them both in the operating room and also using a Geiger counter to measure radioactivity of technetium. And when we reported, unfortunately, the overall sensitivity of this technique was only 71%. There were 2 false negative, meaning 2 patients that were declared as negative based on lymph node biopsy, but in fact they had cancer when we did an inguinal lymph node dissection. So what can you do to improve? Well, they've worked out, and the Europeans have been very good about popularizing and I would say refining this technique using ultrasound to ensure that if there is a node, it's biopsied. And when they do this, the rate of false negative goes less than 5%. And now the new generation of this technique has just been published. This was just published 2 months ago in European Urology. They now are using IGC, which is a green dye, which is often used robotically, combination with a technetium dye. And when the combination of those two is being used, you see here that the performance of this is outstanding. They had no patients ultimately who were missed using the combination of these two techniques. And I would tell you that the drawback with this technique is obviously it's expensive. You have to have the dyes, you have to have the radiologists and radiotechnicians to inject it, and also the surgeons that are familiar in how to do this technique. But you can pick up small little lymph nodes, sometimes node that you wouldn't have not detected using other techniques. So let's talk about managing bulky disease. I mentioned earlier that chemotherapy as a whole does not improve outcomes. Well, it's important to mention there has been what's called phase 2 clinical trial looking at this, using chemo followed by surgery in patients with bulky lymph nodes. They got chemotherapy using a platinum-based chemotherapy for 4 cycles in 30 patients. This was done at MD Anderson. The overall response rate was about 50%. And overall, complete response, meaning no cancer at all when you remove the lymph nodes, was only seen in about 10%. And that last follow-up, patients without any evidence of cancer was seen in only about a third of patients. And only 50% of patients who underwent surgery experienced tumor progression. So these are the survival curves, and it's really highlighting the fact if you respond to chemotherapy, clearly you're going to do better. And if you don't, you're not. So that, you expect that as a conclusion is something that you see. The important factor is how do you predict who is going to respond to chemotherapy and who's not? And that would be an active area of research. It's an area that I'm focusing some of my research in as well as colleagues. This is a meta-analysis taking all the data on chemotherapy together, people always ask, well, what's the bottom line when you take that study, the Pagliaro study and the others, what's the rate or success with chemotherapy? Well, overall response rate is only 53%. So that's a little bit of a flip of the coin. 1 in 2 patients are going to respond. And if you look, how many patients are going to have no cancer? I mentioned the prior study had 10%. If you look at it together, only about 16% of patients will have the cancer completely dissolved when you do the surgery. And the toxicity of the chemo still remains quite high. Grade 3 toxicity, like we were discussing before, is defined as major toxicity, and that was seen in about 40% of patients. We published this paper just a few months ago looking at optimizing the use of neoadjuvant chemotherapy. And the factors that predicted how patients did is the bulkier nodes patients did worse. And if you had a good performance status, meaning if you're physically fit, you did better. Those are, what you would expect. But again, if you did respond to chemotherapy, you did better versus those that did not. And also we develop a nomogram and a calculator to help you predict when you should give adjuvant treatment, meaning you can take all the factors based on the lymph nodes, number of lymph nodes you remove, how much cancer you had, and based on that and the nodal status and the surgical mark status, predict what the risk of recurrence is going to be. So a very useful tool in management. People sometimes ask, well, is there a role for PET-CT in penile cancer? And I'll say, yes, there is, particularly in patients who have palpable disease. So if you have nodes that are physically palpable, the performance of a PET-CT is 96% sensitive. But if you do it in everybody, meaning even those with low volume cancer or those that don't have palpable nodes, only 56% response. So again, not very good. And this is one other paper that looked at this from the group from the Netherlands. And the important factor here is you can pick up small amount of cancer, even in small little lymph nodes using this technique, as you see here in these views. Is there a role to giving adjuvant radiation therapy in patients with penile cancer? This is a paper we published a few years ago. And when we gave adjuvant radiation to patients who had positive pelvic lymph nodes, they in fact did better in terms of overall and disease-specific survival. And these are the differences in the survival curves between the two. So when do I use or recommend radiation? So if the local disease is unresectable, so if they have a large amount of cancer, you don't feel you're going to get it all with negative margins, then obviously giving radiation can be a consideration. Potentially neoadjuvantly before surgery, locally advanced following resection if you have external extension like we discussed before, if the pelvic lymph nodes are positive or if the surgical margins are positive, or some very isolated cases for recurrence. How about managing pelvic lymph nodes? And we'll talk a little bit about that. If there is palpable pelvic lymph nodes in the setting of penile cancer, getting a biopsy, like in the setting of inguinal nodes, makes sense. If they are resectable, you'd want to give chemo and then potentially do surgery if they do respond. If they're not candidates, chemo radiation would be an option for these patients. So now, there is a clinical trial taking place right now. We'll talk about it in the last few slides that is looking specifically at this. So overall, the prognosis of a patient with positive pelvic lymph nodes is traditionally shown to be poor, survival curves of anywhere from 0 to 33%. And there remains still controversy as to the appropriate management of penile cancer in the setting of pelvic lymph nodes. The NCCN and the European guidelines do provide a little bit of information on this. So let's take a look a little bit about, what's the data on this. People always ask, well, what's the appropriate pelvic lymph node dissection template? So this is the external iliac artery. This is the, as you know, the external iliac vein. So you'd want to remove lymph nodes in this area, and the common iliac lymph nodes, preserving the genitofemoral and as well the obturator nerve as well. So this is a paper that was published from the group from Italy. They looked at, well, can we predict which patients are going to have positive pelvic lymph nodes so we can know when we should do a pelvic lymph node dissection? The factors they looked at was 3 or more lymph nodes and lymph nodes greater than 3 centimeters or extranodal extension. If you had all 3 factors, the incidence of having positive pelvic lymph nodes was 57%. And the group from the Netherlands also looked at this in 79 patients, and they found 2 other factors, 2 or more positive angular lymph nodes or extranodal extension were the factors that predicted it. Now, we looked at a different question. We looked at whether you should do a unilateral or a bilateral lymph node dissection. We looked at this in data from 4 centers, over 140 patients. And when you have 4 or more positive angular lymph nodes, you in fact have a higher likelihood of having bilateral positive pelvic lymph nodes. So that's when you should do the surgery. What's the data on pelvic extranodal extension? So Before we're talking about inguinal external extension, meaning when you remove the inguinal lymph nodes, they have external extension. If you see external extension specifically in the pelvic lymph nodes are removed, that's a really, really bad prognostic factor. And in fact, we found that giving chemotherapy in those patients improved survival. These are the survival curves. Now, it's important when you look at data like this to remember some of the patients did not get chemotherapy because they were probably progressing quite quickly. So there is a little bit of a bias when you look at this data, but no question, if they have a good performance status and they have pelvic external extension, it probably makes sense to give them chemotherapy. So I do think some of the data I just discussed with you gives us a little bit more additional information when you should ultimately treat these patients and the extent of the operation you need to perform for patients. The group from the Netherlands also looked at patterns of recurrence of penile cancer after you treat patients. They looked at 700 patients that were treated at 2 centers, and you see that most recurrences will happen the first 5 years. All patients with distant recurrences typically will recur in the first 6 to 12 months and unfortunately will die in the first 2 years. So you see here again, recurrences that are distant happen early and unfortunately patients often die. Local and regional recurrences, typically they'll happen anywhere in the first 5 years. And when you look at, this is some data that we're actually in the process of publishing, you see that patients that do not recur or recur locally have excellent outcomes versus patients who recur in the inguinal, pelvic, or distant disease. These are the survival curves they follow. And based on that, we've sort of looked at how we should survey patients. So developing optimal surveillance strategies to pick up 95% of the recurrences. And again, a lot of this will depend on the nodal status, meaning are they N0, N1 versus N1 or N2? Those are the really important factor in terms of predicting these things. These are also some curves and plots, violent plots, which show you when these recurrences happen and how patients are going to do. Again, it helps you sort of tailor how you should follow patients. So we're just going to spend the last few minutes talking about how you manage a local regional recurrence, meaning the patient had surgery of the inguinal lymph nodes, an inguinal lymph node dissection. Now they've recurred in the inguinal lymph node area without distant disease, so no other areas of disease. Most of these recurrences happen early in the first year or two. And unfortunately, these patients oftentimes will progress if you don't treat them, so you should probably do something about them. We looked at this. We looked at treating these patients with chemotherapy and then aggressive surgery. And we looked at this. You see that some patients did, in fact, have a benefit. About 50% of patients, in fact, had improvement in survival. The other option for a local regional recurrence, other than surgery and chemo, is radiation. And our counterparts, again, from the Netherlands, have looked at this. And overall, the median survival is only about 5 months, and most of these patients progress very quickly. So salvage radiation is probably not a very effective treatment modality to treat a local regional recurrence. How about doing surgery for lymph nodes that are a little higher up, meaning in the retroperitoneum? That's important to say. If they have multiple lymph nodes in the retroperitoneum, those patients are not likely going to be cured. You would treat them with chemotherapy or chemo and radiotherapy. But what happens in a patient like this one here, where you have an isolated lymph node, particularly if it happens a few years later, you give them chemotherapy. On the PET, you see only a single node. Is there a reasonable option to do surgery? And I would say in certain instances, yes. We looked at it in this series, again, 3 patients out of all the years and many, many patients we treated, so highly selected group of patients, and they've done well. Now, when you do salvage surgery and you have to sometimes remove the skin, you sometimes unfortunately have to take some local tissue to cover the area. And this is as well a rectus muscle rotational flap where this is brought in to cover the blood vessels, which are very exposed. It's major surgery, and oftentimes I'll do it with my reconstructive colleagues. And these are the outcomes. You see high risk of complications. This is major, major surgery, redo surgery. So oftentimes these are patients that have had a lot of treatment, chemo, radiation, sometimes are malnourished, and oftentimes are going to have complications. Even these patients where the surgery was being done for curative intent, you see that some patients progress of their disease, unfortunately. And so it's important to tailor this approach to those patients that are ultimately going to benefit the most. Again, as mentioned, even at centers of excellence, high volume centers, you see the rates of complications are really high, close to about 80 to 85%. The study I was mentioning to you that's going on right now is called the IMPACT trial. It's taking place across the world in Europe, in the US and Canada. It's looking at really trying to get good data in terms of giving patients chemotherapy followed by surgery or chemo and radiation followed by surgery. This is the paradigm, meaning if you have bulky lymph nodes, so lymph nodes greater than 3 to 4 centimeters, you're randomized to surgery, chemotherapy before surgery, or chemotherapy and radiotherapy before surgery. If they have aggressive features at the time of surgery, they then go on to randomization 2. Randomization 2 means they go on to either adjuvant chemoradiation or a pelvic lymph node dissection. So this study is going to help us really try to determine, with really high quality data across the world and using very standardized surgery, chemo, and radiation, the benefits of this approach. This is the society. If any of you are interested, please jot down our website, our Twitter handle. We have exciting webinars, both for clinicians, for patients out there. Love to hear from you. It's free. You can join as members. And as disclosure, I am the president of the society, but it is a wonderful society, which I'm privileged to be involved with, which I think definitely is meant to be a global society. So we're excited to have our friends in Africa be part of this, like much other parts of the world where unfortunately we need to know a little bit more about the types of patients we're seeing with these cancers. The IMPACT trial, like I mentioned, is taking place across centers across the world, and we're excited it's going to be answering some meaningful questions. As I mentioned, this global society is involving many other thought leaders across the world. And last but not least, this is my coordinates, my email, and I am Canadian trained. Some of you may or may not know that. So I leave you with an important quote. The good physician treats the disease. The great physician treats the patient who has the disease. So, you know, I talked to you a lot about a lot of data, a lot of literature out there. It's important to remember the patient that you're seeing in front of you is a very unique patient. So they have certain fears, certain concerns. Their cancers are very unique. So these are just some of the additional information may help you treat these patients, but you need to personalize your approach based on these things. On that note, that's the end of my slides. I'm happy to answer any questions anyone may have, and I hope this was of value to everyone. Any questions? Well, definitely. I hope this this slide presentation was useful. I hope that if you have any questions, feel free to reach out to me at any point through my email or other.
Hello.
Yeah, hi.
I'm called Dr. Frank Asimwe from Uganda. Thank you very much for your presentation. It's enriched my knowledge and practice. Just one thing about the radiotherapy. For a long time, we thought that most of these CA penises were squamous cell and therefore irresponsive to radiotherapy. What has changed? Is it the pathology or is it the radiology innovations that we now recommend radiotherapy?
It's a great question. So I would tell you, Frank, that's a question that's probably a combination. You mentioned two factors, but they're probably highly relevant to the answer. Is we're realizing the HPV positive tumors are much more radiosensitive. We have a publication that was just published a few months ago showing that. But I was also tell you, we're realizing also, and we have some good data looking at this, that these tumors are radio resistant as a whole. And therefore, sometimes we need to give higher dosages to these radio-resistant tumors to elicit an effective radiation kill of the cancer cells local regionally. So it's probably a combination of those two factors.
Thank you.
You're welcome.
I have a question.
Yeah, sure.
Yes, Dr. Philippe. What about reconstruction? What forms of reconstructions do you usually do for after the penectomy? You talked about it, but it didn't elaborate more.
Yeah, so whenever possible, glanzectomy. So if I don't need to do a formal partial penectomy, glanzectomy, I think it gives a very excellent cosmetic result. Oftentimes you could take a lot of the skin on the ventrum, what I refer to as a ventral phalloplasty, take all that tissue down, and oftentimes that'll lengthen the penile stump quite a bit. And the reconstructive techniques that I've been working on with my plastic counterparts a lot is oftentimes you can do a fairly aggressive either liposuction or resection of a lot of the surrounding tissue, particularly the suprapubic skin and fat, to increase the functional penile length. And oftentimes you can sometimes do a penile sparing approach in a patient that ultimately you didn't feel necessarily was going to be a candidate, particularly if they have those characteristics.
Okay, thank you. Then the other question, for patients who have palpable inguinal lymph nodes, maybe one side, when you go to do the dissection, do you do the pelvis at the same time? Do you depend on a frozen section, or do you first wait for the pathology to come before doing the pelvic dissection?
So good question. So if the pelvic nodes are not seen on any imaging studies, I typically will wait for the final pathology to determine if I'm going to do the pelvic nodes. Oftentimes it's because our frozen sections are not very good for giving me accurate assessment of number of positive nodes, and also some of the factors like extranodal extension. So oftentimes I will depend on a formal pathology report to make that decision.
Okay. Thank you. Members, any more questions? You can raise your hand or unmute yourself and ask before we conclude.
Well, it's a pleasure.
I've not seen any more questions, and Dr. Katie she's muted. I don't know that she's still
Oh yeah,
moderating.
yeah, it sounds like we don't have any more questions, but thank you so much for presenting, Dr. Spiess.
You're very welcome, and very best wishes to everybody in Africa and Uganda, and stay safe, and hopefully we'll see one another beyond virtually in the years to come.
Yeah,
Yes,
thank
thank you.
Thank you very much.
All the best.
Okay, thank you so much.
Take care, Katie.